That's good. Thank you very much for inviting me. My name is Jeff Mechianick. I'm an endocrinologist here at Mount Sinai. What I'm going to do is I'm going to speak on abnormal adiposity. Here are my disclosures. But I want you to sort of expand your thinking a little bit. I want to present to you a different lexicon, a different way to think about and use a different terminology for these metabolic disorders, these chronic metabolic disorders, and specifically the cardiometabolic drivers. So there'll be new terms. Now, the new terms are actually useful. They're needed because we have emerging scientific data, and it's hard for them to shoehorn into the terms that we have had before. We're going to start off with reframing, redefining obesity as adiposity-based chronic disease. We'll talk about some of the theoretical modeling, the epidemiology, and the mechanisms. And then we'll go through a survey of the different forms and types of eutopic and ectopic fat, their correlations with cardiovascular disease. But really, the end game here is to expose to recognize research gaps, questions without answers, knowledge gaps, answers without awareness, and practice gaps, awareness without action. That's what plagues us in the hospital when we're rounding and we're trying to help a patient. So the different types of fat, eutopic in adipose tissue, that's fat where it's supposed to be, and ectopic, not in adipose tissue. Now, there's a little bit of a gray area here, but eutopic we can divide into subcutaneous and actually visceral fat. The visceral fat surrounding the GI organs, stomach, liver, intestine, but it's also associated with ectopic fat. Now, it's the ectopic fat. This is where the money is. This is where you see the inflammation, the root cause for insulin resistance. And not only are you seeing it in the liver, we heard a great talk about the ectopic fat in the liver, but also the kidney. A colleague of mine, Dan Einhorn in San Diego, described fatty kidney disease. I'll show you a slide on that. In the muscle, you'll hear a talk on sarcopenia next. In the heart, 4 different areas in the heart: epicardial, pericardial, paracardial, and around the coronary arteries, and also a 5th, intramyocardial. These are all playing roles. This is sort of the black box we've been looking for to account for a lot of the phenomenon that we had difficulty explaining. Pancreatic fat, the lipotoxicity, the beta cell apoptosis, the association of the loss of beta cell reserve that gives you that hyperglycemia in the insulin resistant state. Remembering that insulin resistance, you have euglycemia. You don't necessarily have to have the hyperglycemia, and actually also in the lung. In the lung, the hyperresponsiveness of airways. So let's begin with a new concept, which is driver-based chronic disease modeling. I did a lot of work with network analysis, looking at complexity. And what occurred to me is that chronic diseases, which are very complicated, we all have 3 or more chronic diseases as we get older, and a vast number of drivers. And in network analysis, there's small world phenomenon, there are dominant drivers. And the phenotype of the chronic disease can be, you can look at the root cause, which is a dominant driver. So to the left, you see adiposity-based chronic disease. This is what we did differently. Instead of defining obesity solely in terms of the BMI, which clearly failed us, right, for a lot of the pitfalls of BMI, body mass index, we expanded it. We said you can have abnormal adiposity, not just with increased amount, but abnormal distribution, the ectopic fat, and even abnormal function. If adiponectin, leptin ratios and CRPs and a lot of the other inflammatory cytokines are ready for prime time, we would actually have a signature of an abnormal adipocyte secretome that would define abnormal adiposity. And then in the proper context, we get the burden of disease. In fact, the European Association for the Study of Obesity adopted our ACE, American Association of Clinical Endocrinology, terminology for ABCD, a lot of letters here, ABCD, adiposity-based chronic disease. We then moved on to DBCD, dysglycemia-based chronic disease. a group at Mayo, they were calling attention to the fact it's not really cost effective to treat prediabetes. What are you going to do? Throw metformin on? And remember, this is before we had all the CVOT drugs, the GLP-1s and SGLT2s. But are you going to start treating with pharmacology just because you had prediabetes? The number of lives saved, the cost effectiveness wasn't really there. We redefined it. We looked at prediabetes not in isolation, but rather in a spectrum of insulin resistance to prediabetes, to type 2 diabetes, to complications. And to the right, we did it for hypertension. We have new malnutrition for residual risk and lipid-based chronic disease models coming out. When we put it all together, this was a double paper in JACC, we build this holistic model of cardiometabolic-based chronic disease. And to the right, you can see the centrality where it focuses on insulin resistance. And you can see where it's shaded in green, where you have the abnormal distribution, and that's the ectopic fat or the visceral fat. So let's just go through a survey of what we're talking about. Why do we have increased ectopic fat to begin with? So Scott Grundy was really one of the first to look at this and say, when you eat, if you have an unhealthy diet, right, unhealthy lifestyle, all that extra calories and the fat, it's got to go to subcutaneous tissue. At some point, the subcutaneous fat says, no more, I'm done. I'm all tanked up. And so the fatty acids have to go somewhere else. And you can see to the left, the phenotype, if you have a gynoid habitus, and it's in the eutopic subcutaneous depot, or on the right, an android habitus, more visceral fat, ectopic fat, and that's what's causing the disease. It's not just about the BMI. Here are some very cool imaging studies that are done, which really can show you, at least for the heart, the differences between the epicardial fat adjacent to the myocardium, and then you have the pericardial fat, and then outside the paracardial fat, and around the coronary arteries, you have pericoronary adipose tissue. And they all correlate with different aspects of metabolic syndrome or cardiometabolic-based chronic disease. In fact, patients who have visceral adiposity, those are the patients who then have this ectopic fat around the heart, and it correlates with the different cardiovascular diseases that have metabolic drivers: atherosclerosis or coronary artery disease, atrial fibrillation, and heart failure. If you look here, you can see that even the pericardial fat is associated with those cardiometabolic diseases, particularly atrial fibrillation. Here you can see some of the mechanisms. The mechanisms involve the adipokine elaboration of the pericardial fat, and the way it affects reentrant rhythms and atrial fibrillation. Can you decrease this epicardial and pericardial fat? And you can. In fact, lifestyle interventions are always the best. If you look at our guidelines and if you look at the MASL data, the weight loss and the dietary manipulations, they're going to work the best. But we have drugs, the TZDs work, and of course the GLP-1s and the SGLT2s can work. There's intramyocardial fat. So the coronary heart disease, when the muscle is involved, and you see depots of this abnormal fat actually in the muscle, and particularly when it's around the pulmonary veins, that's what's correlating with atrial fibrillation. Here you can see to the far left, the MASLD, in the middle, the fatty kidney disease with the kind of gross picture there of the kidney, right? It looks like a butcher had their way with it. And then on the right side, you can see pancreatic fat and some of the molecular mechanisms. Myosteatosis, a fancy word just for the fat inside the muscle, and this is what you see with the sarcopenia, particularly with neurodegenerative disease and myocardial dysfunction. And then finally, the lipid chaperone molecule, fatty acid binding protein 4, playing a central role in ectopic fat in the lungs with reactive airway. Let me conclude. Research gaps. These are the questions without answers. We need basic science, preclinical and clinical studies relating the various aspects of ABCD with cardiometabolic physiology, and we need pragmatic clinical trials that mimic what we actually do in medicine, to use these findings, these holistic findings on CAT scan related to abnormal adiposity and correlate them with the cardiometabolic derangements. We need to teach this. We need to teach this to our trainees, get them asking for this information to assist with ABCD decision-making. And lastly, our practice gaps, which are to include on a routine basis, and this was a comment that was made in the last session, that we should be using this information routinely, and we should build this imaging infrastructure for facile and inexpensive technologies. Thank you.